Please make sure to double check that you are muted. And during the presentation, Megan will put the CME code in the chat. Please remember, if you are going to be texting the CME code, you need to include the word attend and then the code, not just the code. So this morning, we're very excited to have Dr. Khan with us for an always needed update in epilepsy. Dr. Khan did her pediatric as well as pediatric neurology training at UT Southwestern in Dallas, and then stayed on there to work in the pediatric neurology department until 2016, when we are lucky that she moved out here and joined DMG. She is a member of the American Epilepsy Society, as well as the American Academy of Neurology, and also the Child Neurology Society. We are very excited to get our updates this morning, and I will let Dr. Khan take it away.
Hi, good morning, and thank you for the kind introduction. So I know epilepsy is a huge topic, so I'm just going to touch a little bit about the past and how it has evolved into current and a lot of still the modern misconceptions that we have about epilepsy, and then some of the newer, one of the biggest things that has happened in the last few years is like the reclassification of how the seizures should be classified. So I'll touch a little bit upon that, and then some of the newer devices which are in the pipeline. So if you look at people use the term seizure and epilepsy interchangeably. So seizure is basically, as you all know, it's a symptom. And then if you have more than one seizure, then we call it epilepsy. So the term seizure actually comes from the Latin word sacre, which means to hold on to. And the term epilepsy comes from the Greek word epilambanian, which means to be seized, to take hold on, or to attack. And this belief is reflected because previously it was believed that the people who have epilepsy has been seized or claimed by supernatural powers, spirit, or God, depending on which part of the world and which religion's beliefs they had. So if you look at how far back in the history epilepsy has been dated, so it goes back as much as like 3,000 to 4,000 BC. And there is a tablet, Akkadian tablet, which was found in Mesopotamia, and it gives a very clear description even then. It's this person whose neck is turned with extremities tense, with eyes open, frothing at the mouth, and loss of consciousness, which all of us know we call it generalized tonic-clonic seizures these days. So, and then there is a Babylonian clay tablet, which is now present in the British Museum. And that also gives, with these tablets, they're called Sakaku, which means all disease. And they give guidelines about different diseases. And it's one of the very first, not the first, but the best preserved description of diseases from the past. And in that it gives, say, effect, and this is what it says about seizures, is if at time of his possession, while he's sitting down, his left eye moved to the side, which what we call focality these days, lips pucker, saliva flows out of the mouth, a lot of people call it frothing these days, and his legs, hand, legs, and trunk on the left side jerk like a newly slaughtered sheep. And they use the term miktu, which means to fall. And then it further says on that if at the time of possession, his mind is consciously aware, which the old classification was a simple partial seizure, and the demons can be drawn out. And if at times of possession, his mind is not awake, which now the old classification was complex partial seizures, the demons cannot be driven out. So with this description, if you translate it today, it actually, with the newer classification, it would classify as a focal unaware tonic seizure. And then the tablet also uses other terms such as hayatu, which fit. And in a lot of cultures, they still call it a fit, or septu, which signifies seizure. So over the years, these terms have been used interchangeably. So, and interestingly, even at that point in time, like 2000 years BC, they still have given descriptions of several different seizure types and characterized them based on the description. So, and then even if you look at the Sumerian term, Sumerians also described it, and they call it Antasabu, which means the falling disease. And they predict it is as people who have sinned, and so it is kind of because of their sin, they have been punished by the god of moon. And so and that's where actually the term often lunatic comes from. And interestingly, so this was then, and this is more recent in 1976. Actually, so when they thought because it was sin, during mid-centuries in 1500 and around that timeline, they were actually using exorcism. And we don't have to go very much back in history to look at that. And in 1976, a girl, 24-year-old student in Germany died. And what appeared to be like, she was battered, she has like black eyes, she has cuts, she was starving. Her weight at the time of death was 68 pounds. And then the father who did perform the exorcism explained to the district attorney that he was conducting a series of exorcism, believing her to be demonically possessed. And they even made a movie, Exorcism of Emily Rose. Going again back into the history, so we have Hammurabi, the Code of Hammurabi, which was between 1755 to 1750. And so this is one of the legal text in the Babylon, and this is the longest and is best organized and best preserved. And it was found where the modern day Mesopotamia is. And this came about by the orders of the sixth king of the first dynasty in Babylon. And in addition to a lot of laws about how people should be living, and he was interested in like justice and making sure that there are laws followed in the society. But interestingly, for people with epilepsy, there were laws that they could not marry, they could not testify in court, and even if they were purchased as slaves, and if they have epilepsy within the first 3 months of purchase, the contract was void, and you could give the slave back. So this is how those people were treated. And interestingly, about the marriage law, it was the last state to remove the marriage law, even in United States, was in 1980. So until before 1980, people with epilepsy could not marry. So as time passed by from them into the ancient Greeks, so the ancient Greeks actually thought of it as more and associated it more with their gods. So instead of associating with demons and all, they started to associate it with that it's a gift of God to people who are special, and then it started calling it as a sacred disease, or the divine disease is another term which we'll come across in the history. So, and it wasn't until Hippocrates, 400 BC, that he rejected the idea that no, it's not a sacred disease, or it's not by demons or spirits. It's actually a disorder of the brain, which is treatable. And then he even went as much as like he talked about that it's a hereditary factor is involved, which is worse when it starts early on in the age, which we all know now. And he actually described it as a great disease, and hence that's where the old terminology came, the grand mal seizures, or what is called as generalized tonic-clonic seizures. And then going further, Egyptians in 1700 BC, they actually reported a case where of a man who had a gaping wound in his head, and then when they stimulated the wound, on the surface of the brain, he had a shuddering of his shoulders. So even the Egyptians at that time have started to say that it's a physiological illness and nothing to do with the spirits. And then the Chinese text also talks about during the Yellow Emperor's classics of internal medicine around 700 BC about the generalized seizures, so forth. And then on the east, so this was Avicenna also recognized it as a brain illness. He even said like it is worsened with insomnia, intensive sounds and lights to be provocative factors. And so, which is what he's describing sleep deprivation. He's actually talking about startle epilepsy and reflex epilepsies, which is the term which we use nowadays. So in spite of like the Hippocrates work and the work on the East, all it so throughout the first 1,000 years, it still continued to be blamed to the spirits until the 17th century. So mm, and then in the Middle Ages, interestingly, the concept of contagiousness that it came around. So it was thought that this is a contagious disease. So most of those peoples were like moved out of the society, and they would have separate boarding and lodging at the outskirts of the city. And a lot of text would report, so you should not talk with them, bathe with them, or they breathe infectious to the people. So, and this unfortunately continued even into the 18th and century. So in US, interestingly, 19th century, they opened a number of colonies and residential institutes for people with epilepsy. So the first one was in Ohio, and they called it Ohio Asylum of Epileptics and Epileptic Insane. So, and so several of these open up like in, especially mostly around the East Coast in Pennsylvania, New York. And a lot of these, interestingly, these institutes were self-sufficient. Like they grew their own food, they managed their, so it was like a whole society within, so they are not dependent on people from outside. So, and so people were feared, people were isolated, and they suffered discrimination. And even now to this end, I mean, I still meet with young adults who want to work and they have seizures at work. And I have this young girl who's 22 years old. She's been fired from 2 jobs. And although there are the laws are a lot more protective these days, but still it there is a lot of taboo. And especially this is more in the third world countries, where I'm originally from Pakistan, where I would still see people who would say that they have been under the influence of a demon or jinn, as we call it in our language. And the people were actually sterilized before 1970. The girls were sterilized. They had to have hysterectomies done for that. So, and then finally, in the late 1800s and all, when the formal studies about the uh, um, um, uh, uh, epilepsy started, said that's when Dr. Todd, as we all know about Todd's paralysis, he finally defined that its brain's function is through an electrical force. And he hypothesized that it's the electrical discharges in the brain that may be causing the seizure. And then he actually proved it later using Faraday's a magnetoelectric rotation machine on rabbits. And then later on, Dr. Jackson from Scotland, he laid basically the foundation of epileptology. He was able to localize the lesions, and there is actually a seizure type for his name, which is called as the Jacksonian March, which a lot of people we would know, like if the seizure starts, say, from one spot, it starts with the face, and then twitching of the mouth, and then, spread involving into the arm and the leg. So that is what we call the Jacksonian March. And then 80 years after that is when Hans Berger invented the human EEG machine. And then I'm going to talk a little bit now about the drugs. So since 1800s, since it was now started to be recognized as an organic brain disease, but there was no medications available. So the first medication which came out was in 1800s by Dr. Charles Locke, and he was actually, interestingly, an obstetrician to the Queen Victoria. So he introduced the potassium bromide as the treatment of epilepsy. And actually, this was also by chance. So he was actually trying to find something to cure, for sedation purposes, basically. So primarily when he came out with the bromides, he was using it as for sedation. Um, and then he reported that he used this medicine in about 14, 15 young ladies who, some of them interestingly ended up having seizures. So their seizures suppressed. So that's how it kind of, just by chance, they found out that, hey, it does affect, it helps treat with the epilepsy. But the use was limited because of the side effects, sedation, MSS. Interestingly, bromides are still used as the epilepsy drugs, and it's mostly used in the animals, especially dogs, when they have seizures. Very rarely, every once in a while, people have used it even for intractable epilepsy. So even 150 years later, if everything else has failed, this is some of the epileptologists have used bromide. The other thing about it, it's very cheap too. And then came about the famous phenobarbital, which we all know. So phenobarbital has an interesting history, and also its use as in the epilepsy was also by chance they found out. So the initial compound was made by Joanne Baer from the Baer Pharmaceutical Industries, and he actually made the compound somewhere in like 1882 someplace, but he did not know of much use to it. So after he found the compound, new compound, which was malonyl urea, he went to a pub where he saw St. Barbara, and then he decided to call the new compound Barbara plus urea, so barbituric acid. So it was placed on hold at Bayer Pharmaceuticals because they did not know what to do it. And then in early 1900s, 1903, they started to experiment and found out that it was making the dogs sedated. So they initially marketed it as hypnotics. And then I think in 1903, there was a psychiatrist by the name of Alfred Hopman who decided to use it to sedate some of his epilepsy patients. And then he found it stops the seizures. And that's how it started to become used for epilepsy. And this is one of the few medicines still being very largely used for seizure management, and especially in the neonates, it is still the drug of choice. In status epilepticus, like if phosphene fails, we go to phenobarbital load, and some of the kids I have where everything else has failed, but phenobarbital has helped. Sedation effect definitely is still there, but it is still being used, and especially also in the third world countries, and it's dirt cheap. It's like the whole month supply is like a couple of dollars. Then in 1936 came along the phosphonatoin, and then in 64 valproic acid. And then after that, so this is the chart published in Epilepsia, which tells about all the anti-epileptics. It goes up till I think 2015, but after the everolimus, there has been cenobamate was just approved last year. No, 2 years ago. And then Epidiolex also is one of the newer ones, and Perampamil. So there has been 3-4 more new ones after this one. And so total now we have approximately 32 anti-epileptics medication. The more newer ones are like third generation. So even though with so many medications in the market, and the newer ones have a better pharmacokinetic profile, they have lesser side effects, and they have novel molecular targets, but it has still not yet significantly improved the therapeutic efficacy. So if you look at the literature over the last, even 50 years ago, when we talk about any people who presents with epilepsy, 1/3 will remain intractable. And even to this day today, 1/3 still remain intractable. None of the medications we see in this will make people 100 seizure-free completely. So I'm specifically talking about drug-resistant epilepsy. So as we all know that when people present with epilepsy, 2/3 will become seizure-free with the first medicine. It is these 1/3 people where we use all of this and other treatment modalities. So, and if you look at all the studies done for most of these seizures, they always talk about, so very rarely they will say seizure freedom. It's always they talk about it's a seizure reduction. And in most of all of these anti-epileptics, the seizure reduction is 30-40%. Cenobamate, we just came out 2 years ago, is probably the first one which they actually said the seizure reduction is down by 50%. Like this is like the big, mostly it was always around 35 to 40. None of these have up to 50% seizure reduction. And again, it's seizure reduction. It's not seizure freedom. So if you look at how many people have in histories have epilepsy, so the reports say Socrates, Michelangelo, Van Gogh, Napoleon Bonaparte, and a lot of writers like Agatha Christie, Charles Dickens, Edgar Poe, even musicians like Elton John, Prince. So a lot of famous people have epilepsy. And even though we say we advise not to play football, but some of the NFL players have epilepsy, and a lot of them did not declare it until later on in their careers. So the presidents have it. I think one of the more recent one, Cameron Boyce, I've put in kids who all of you who have younger kids, probably in their early teens, may remember him. So he was one of the famous actors through the Disney Channel on a series called Descendants. So Descendants were basically the kids of these famous princesses. We all grew up with, like the Snow White and Cinderella. So these were the kids. So he played one of those characters, and the third sequel was coming out in just before COVID, I think 2018. It was just 3 weeks away from being released in the cinema, and where he passed away with SUDIP. That's when his family actually said. And that was the one summer where a lot of teenagers asked me these questions like, do you think we're going to die in our sleep because of the seizures? Which is a reality and which we often don't even talk about it. So if you look at the epidemiology, I mean, you all know that there is it affects about 1% of the population. That means all of us have 1% chance of having seizure in a lifetime. That means everybody, even me, who have never had epilepsy. And in US, it affects about approximately 2.5 million people with 150 to 200,000 new cases every year. And in the CDC website in 2015 reports about 1.2% of the total US population with active epilepsy. And out of those 3.4 people, so that was equivalent to 3.4 million people with epilepsy. 3 million were adults and about 500,000 were kids. So that means 0.6% of 0 to 17 years of children have epilepsy. And so if you look at it, like if a school has 1,000 kids, which a lot of schools do, at least 6 of them may have epilepsy. So it's a 4th common neurological disorder after migraine, strokes, and Alzheimer's. And 1 in 26 will develop epilepsy at some point in their lives. In neonates, the incidence is about 1.1 to 5.5 per 1,000 live births. And then, so the American Academy of Neurology and the Epilepsy Society, they published guidelines about SUDIP, which I just discussed. So SUDIP stands for sudden unexpected death in epilepsy. And in 2017, they said the incidence per 1,000 epilepsy person years was about 0.2 in children and 1.2 in adults. So, and actually there has been a newer paper which was published in 2018, which actually stating that the incidence rate of SUDIP is the same in children as well as in adults. and again, even to this day, there is a lot of social stigma attached to it. There's discrimination, especially if a child has a grand mal or a convulsive seizure at school. They are embarrassed, and some of them don't want to go to school. They're bullied. I had one 12-year-old where she had the seizure, and then next day onwards, they were calling her, "Oh, you were like a fish out of water," and she was in tears, and she had to literally change her school because of that situation. And it also puts in a very high economic burden, and the cost is estimated to be about $28 million a year. So the funding is not, if you look at the relative funding for the neurological diseases, epilepsy has nothing even close to Alzheimer's, cardiovascular, or the heart disease. So moving a little bit to the classification. So International League Against Epilepsy is the organization which was started approximately about 1,000 years ago, and it was started as a reaction again when all of these institutes were made all over US with people with epilepsy living in separate communities. So this organization was started to work to support their rights. And over the years, it has come around giving different classifications. I think the most common one which we were used was in 1986. Then there was a revision in 2010, and then finally in 2017. And so a lot of the terms have become are advised not to use anymore. So I'm just going to touch a little bit upon then how to classify newer through this new classification. So they published the guidelines in 2017. So basically, the difference between the old classification and the newer classification is the language. So the newer classification is using the word that means what they say, and the main purpose is the clinical diagnosis. So it basically classifies epilepsy at 3 levels. So first, when somebody comes in with a seizure, we as neurologists have to think of, okay, what type of a seizure this person has. And once we do that, then what type of epilepsy they have. And then the third step will they fit into any epileptic syndrome? So the 4 main broad components is, so when you talk about the seizure type, so seizure types would be of 3: the focal onset, which the old term was localization related or partial seizures, and then there is a generalized onset, and then there is a third one where unknown onset. Now, unknown onset does not mean that there is such a type of a seizure which is unknown. It's just we are still ignorant and we still don't know how to classify that particular seizure. So for now, we would put it in that category with the hope that as time passes by, we may be able to classify it better. And then once you know the seizure type, then you go into the types of epilepsy. And again, type of epilepsy would be a focal, generalized, and then there is a type which is combined generalized and focal, and then again the unknown. And then we have the syndromes, and the other new thing which they have added as now we are knowing more about the etiology. So, and the etiology could be either structural, genetic, metabolic, infectious, and immune. So if you look at this cartoon, so we start with the seizure type being either focal onset or generalized onset. And then so and then so we'll start with the focal. So once you know if the seizure onset is focal, then we have to know whether there is awareness or unawareness. So that's the second. Let me go back forward a little bit. This one. Okay, so you need to decide whether there is awareness or there is loss of awareness. If they were aware in the initial part of the seizure, but then they lost the awareness after that, it will still be classified as um, uh, unaware. And then there was another one. Okay, yeah, this one. So once you classify the focal onset seizure into aware and impaired awareness, so then the impaired aware with the aware focal aware seizures, these were previously called as simple partial seizures. Then you have to decide whether there is a motor onset or there's a non-motor onset. So when we talk about motor motor onset, so then they could have 5. So they could have automatism. So the term automatism means where movements are performed which the patient is not aware of, but it looks purposeful, but there is actually no purpose to it. So sometimes like they will be fumbling with the hand or fumbling with their clothes. So that's automatism. So, or if there is atonic or if there is clonic, epileptic spasms, and then hyperkinetic, myoclonic, and then tonic. So hyperkinetic often is seen in the frontal lobe seizures where they have erratic movements. So with atonic, as it sounds like, you lose the tone, and then the clonic is when you stiffen up, and epileptic spasms. And then so if when somebody who's describing the seizure should tell you about any motor component, then those are non-motor seizures. And in non-motor seizures, so although they don't have any physical movement, they can have either autonomic symptoms, um, um, behavior arrest, cognitive, emotional, or sensory. So when we talk about so actually we can use the term now like cognitive seizures. So when you say what is cognitive seizures, so in these it would be they can have deja vu or jamais vu sensation at the onset of the seizure. So the important part is how the seizure started. And that's where a lot of times that history is not available, but if it is, that's how you would describe this. Um, so there can be memory impairment, there can be neglect, illusions, hallucinations with the cognitive seizures. Then the other term we use is the emotional seizure. So when you talk about emotional, is a lot of people would say, for example, they felt fear. So that would come under the emotional seizure. So they can have fear, anxiety, laughing, as we see in the gelastic seizures, and paranoia, pleasure. And then when we talk about um, autonomic seizures. So in autonomic seizures, they can bradycardia, flushing, GI symptoms like epigastric uprising. They would describe it as like butterfly sensation in the stomach, hypoventilation, nausea, vomiting, pallor, palpitations, piloerection. So all of those come under autonomic seizures. And then with the automatism, they can have aggression, they can have eye blinking, orofacial movements, pedaling, perseveration, vocalization, and walking. So these are all focal seizures. Now if with the awareness, now if the awareness is impaired, then we call it focal impaired awareness seizures. These were previously called as complex partial seizures. And then again, you do the same classification, whether they had motor onset or non-motor onset. And again, motor onset would be divided into the same, whether do they have automatism, atonic, clonic, epileptic spasm, hyperkinetic, myoclonic. With the older classification, I remember when I was a resident, I was always told that atonic and tonic seizures are generalized. But if you read the literature, some of them could be focal. So they had actually incorporated that into the newer classification. Now, there was another phenomena where the seizures would start and then like as a focal, like say somebody staring off and then having automatism. And then after like say 10-15 seconds, the whole body would shake. So the old terminology was partial onset seizure with secondary generalization. So so now we don't use that term anymore, but now it would say focal to bilateral tonic-clonic seizure is the new term. Um, um, so 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 um, so the second category, the first one was the focal, the second one was the generalized onset. Now with the generalized onset, the difference between the two is there is no awareness and there's no aware and impaired awareness in generalized, because it is presumed most of the generalized seizures, the awareness is impaired. So that's why we don't do that, but we just divide it into, again, motor and non-motor. So with the motor, so it goes back to the same way. We have automatism, atonic, clonic, epileptic spasm, hyperkinetic, myoclonic, and then with the non-motor, autonomic seizures, cognitive seizures, sensory. So same classification for these. Now, now remember the third group, the unknown. If the unknown is, that means unknown is a lot of times used when somebody caught the tail end of the seizure. So, so whatever we know, we do still try to divide it into between the motor and the non-motor. And then as time passes by, if with the help of the EEG or epilepsy monitoring unit, we can classify it better, then they moved into the other groups. So these are the terminologies we no longer use. So the complex partial, simple partial, psychogenic, dyscognitive, secondarily generalized, tonic-clonic, and the petite mal seizures. So these are examples of some of the older terminologies and what they're called new. So like I said previously, so partial seizures are now called focal seizures, and focal seizures with secondary generalization are now called focal to bilateral tonic-clonic. And the reason for that is we presume that the focal seizures are occurring in only one hemisphere, versus when we talk about generalization, it's the network circuitry is in the whole brain. And simple partial before is now called focal aware. The psychomotor and disconjugate seizures are now called focal impaired awareness. The grand mal is generalized tonic-clonic. Infantile spasms are now called epileptic spasms. So infantile spasms still, although it's called epileptic spasms, they still occur in infancy. So you don't see epileptic spasms in adults. So, and we go back a little bit. Let me show you. So this is what we talk about when we say generalized seizure. So the onset, it's like pretty rapid with distribution in both the hemispheres. Versus when we talk about focal, it remains in one hemisphere and or into the other. So okay, this is pretty much the same what I just said. So the generalized onset. So atonic seizures is also called drop attacks. And interestingly, often the atonic people who have atonic seizures, they fall forward. And if they have tonic seizures, then they fall backwards. And they're stiff. Again, the other thing is also they're very brief. So atonic seizures are not more than 15 to 20 seconds. Myoclonics are also very brief, sometimes 2 to 3 seconds. So myoclonic seizures are like sudden jerks of the body. And they often occur in clusters. So when we are talking about duration, it's again primarily of the focal seizures that the duration is longer than 1 minute. Epson seizures come under generalized category, and they're still the definition is still the same, very short, sudden onset, sudden ending with like no postictal phase. So so absences are in the generalized. So so this report came actually last year. So if you go, so if you go back to this one, where did we? This, okay. So in 2017, they talked about seizure types and the epilepsy types, but they did not talk about epilepsy syndromes. So epilepsy syndromes have been identified for like 50 plus years, and you guys all know about West syndrome, Lennox-Gastaut syndrome, Dravet syndrome. So how would you classify that? So that classification was published last year in 2021-22. And then in that one, so with the so once you reach the seizure classification, you can try to see if would this person with epilepsy, would it fit into one of the syndromes or not, but not necessarily all of them will fit into a syndrome. And the way they have divided the epileptic syndrome is by the age. And they also have specific seizure types. And it's important to still know about the syndromes because it tells you about the prognosis. So like, for example, if you know West syndrome, you know that they will have continue to have intractable seizures, most likely. They will continue to have developmental disabilities. So as soon as I say this term, a lot of those things starts to come to your mind. So prognosis and the treatment also can be specific, say for like epileptic spasms, for example, where you use steroid as first line of action. So that's why the syndrome, classifying them becomes is makes it this useful. It also talks about underlying etiology too, and some of the anti-epileptic medications more useful. Another reason that we as an epileptologist need to classify the seizures between focal and generalized is because there are certain anti-epileptic medications which can actually make your seizures worse. So just like antibiotics have, you have broad spectrum and narrow spectrum. Similarly, we have anti-epileptics, which are broad spectrum and narrow spectrum. And if you use the narrow spectrum is often is only for focal seizures. So if you use that narrow spectrum, which is example is carbamazepine, oxcarbazepine, if you use those in generalized epilepsy, such as in kids with Dravet syndrome, SCN1A mutation, you can actually make their seizures worse if they have a generalized onset. So that's why it's important to know the differentiation when you're treating them. And so you can avoid these. So like phenytoin can also make kids with Dravet their seizures worse. So the other new term when you talk about the syndrome is, as you remember, the benign epilepsies. So benign Rolandic epilepsies, benign occipital lobe epilepsies. So the word benign is no longer used. And in fact, the new term is self-limited epilepsy. So, and then in this group is, if you see, it is again divided by age. So then you have self-limited neonatal epilepsy. So these used to be called benign neonatal epilepsies. And then you have familial neonatal, so which is again the benign is termed changed. And then you have genetic epilepsies with GEF plus and the myoclonic. And then the other group is where you see the developmental and the epileptic encephalopathies. And these are also mostly, this is also age related, and you see it in the neonatal period. So they are now classified as this group of developmental and epileptic encephalopathies. So here you will have early infantile development and epileptic encephalopathies, the new term. Some of the older terms, as you guys would remember, was like Otohara syndrome. That all comes over here. And then you have epilepsy in infancy with the migrating focal seizures, infantile epileptic spasm syndrome, and the Dravet syndromes come under this. And then now with the recognition of etiologies, especially the genetic epilepsies, so we can group them into etiology specific. So such as KCNQ2, which also again presents in infantile period, pyridoxine dependent. It was actually in the older classification, it was not even part of the classification, but we knew it was there. So now it has a space in the new classification. And then the CDLK5 is another one, which is new, PCDH19 deficiency, and then GLUT1. Sturge-Weber comes under over here. Gelastic seizures with hypothalamic hamartoma also is over here. So in the old classification, the etiology was not part of it, but now they have added the etiology part also in the new classification. So, uh, g- so talking a little bit about the drug-resistant epilepsy or intractable epilepsy. The definition is failure of adequate trials of two tolerated, appropriately chosen anti-epileptics, and it could be either monotherapy or combined therapy to achieve sustained seizure freedom. So the goal is zero seizures. Now, whether we can achieve that goal or not, but at least we try. Uh, um, so in order to get to seizure freedom, if you fail two medicines, then you have drug-resistant epilepsy. And the rationale for that is because now with the drug-resistant epilepsies, if the medications are not working, then there are other treatment options available, such as specifically epilepsy surgery. Um, um, so so we and and we all know that uncontrolled frequent seizures leads to developmental delay. So this if we can bring the seizures under better control, um, uh, we have to transfer them to epilepsy centers where different options would be given. So so especially with the focal epilepsy, one of the main treatment would be what we call lesionectomy. So what that means that if we know all the seizures are coming from just one spot, and can we safely take out that spot without causing harm to the patient, then we can actually bring seizures under control. And interestingly, we all know that epilepsy, there is no cure for epilepsy except this one. There is only one cure, which is lesionectomy. So, and if you look in the adult literature, they talk about temporal lobe epilepsy very frequently, and and um, and and if the seizures are coming from the temporal lobe, and if you can safely take out part of the anterior temporal lobe, the success rate for seizure freedom is close to 80, and in some studies even 90%. That means 90% will be cured of their epilepsy for the rest of their life. So it's huge, but this number is only for temporal lobe epilepsy. If you talk about extratemporal, which is what we see in pediatric population, extratemporal, the success rate is only 50%. So that's why a lot of times what I have encountered also is when I talk to them about surgery, they're very hesitant. They don't want to. Most of them don't even want to have an evaluation, and it's very hard to convince them that at least you should have an evaluation to see whether you are a candidate or not. Because, for example, if they find more than one foci, so there are 2 or 3 foci of epilepsy, um, then they are not a surgery candidate for lesionectomy only. I'm talking about, and then so. So with the drug-resistant epilepsy, the biggest uh, one of the risk is, as I discussed, SUDEP. And the SUDEP is 1% of the people with epilepsy will die from SUDEP each year. So so SUDEP will happen only with the convulsive seizures and complex partials. So sudden death epilepsy will not occur in, say, Epson seizures or myoclonic seizures. So it's primarily seen with uncontrolled generalized tonic-clonic seizures. And it sometimes become a little tricky to decide when if the death has happened because of the seizure. So when we do the autopsy, they have to be otherwise healthy, no other cause would be found, and the death typically occurs during the seizure or immediately after the seizure. And the hypothesis is cardiac and pulmonary derangement. The ictal EKG studies and the autopsy studies have shown there is a transient ictal conduction abnormalities and myocardial injury, respectively. They can end up having terminal arrhythmias or bradycardia in patients who died on the monitoring unit. Most of the times, when we talk about seizures, it's tachycardia. However, there are some seizures where you have bradycardia. At my old job in Dallas, one time I was monitoring a child where he started having seizures and the heart rate dropped to 30s. and the kid was intractable. So we had to actually put a pacemaker, which is, not, it is not a recommended treatment to use pacemaker, but we had to do it till we found other treatment modalities. So, I mean, these are exceptional cases. This is not a common norm. So, so studies have shown that 1 to 2 people in 1,000 cases of epilepsy per year will have SUDEP. And especially, like I said, uncontrolled epilepsy. And interestingly, SUDEP will take more lives than SIDS in US. So risk factors, again, polypharmacy, drug-resistant epilepsy, chronic long-standing epilepsy, young onset, tonic-clonic mostly, and some complex partials too, nocturnal seizures, non-compliance, developmental delay as a comorbid condition, and then and interestingly, so when we talk about in the case of Cameron Boyce, his seizures were, according to family, was not too bad. I mean, they said he would have maybe 1 seizure a year or 1 to 2. So sometimes it's not even how frequent the seizures are. Basically the bottom line is anybody who has epilepsy is at 1% risk of having SUDEP, even if you're seizure free. And if it is uncontrolled, then the risk is 10%. So a lot of teenagers, when they're non-compliant, I have this discussion about SUDEP with them. And I tell them, it's like, and unfortunately, we have to like really say it clearly. It's like, you will die in your sleep one day. And sometimes that's what it takes them to be compliant with the medications. I'm going to talk a little bit about some of the newer medicines which are in the pipeline. So briefly touched upon cenobamate, which recently started. I have few young adults on it. It's still not approved for children under 18 yet. So the young adults I have, they are like in their early 20s, and 3 of them actually have become seizure free. And before that, they were having seizures, at least 2 to 3 grand mal seizures a month. And 2 of them are very functional, like they finished their high school, they're working. So it's awesome. And in the 4th one, actually, the seizures went down from every 2 weeks to now once every 2-3 months. So that was the cenobamate. And then the genaloxone, which is a neurosteroid, actually this just got approved in August of last year. And interestingly, it has been approved by FDA for CDLK5 disorders, which are the cyclic dependent kinase like this deficiency disorder. This is extremely rare epilepsy. I think I've probably seen in 17 years of my practice, maybe two or 3 cases. So it's very, very rare. So it's a natural neurosteroid and a metabolite of progesterone. And even in this one, like you see, the median reduction is 30% in 28 days of major of the convulsive seizures, as compared to it was 6.9% reduction on the placebo. So the company is now doing trials in the emergency centers. They have about 50 hospitals where they're trying to use this. Can this be used for emergencies? So in the protocol, the first line of action would be the drug of choice, like Ativan and then barbiturate, and the second line would be this one. So we'll see what the results show. Natalizumab is actually already approved. It's a humanized monoclonal antibodies. And it's actually already being used in multiple sclerosis and a lot of those autoimmune disorders. So they're now doing studies, phase 2 studies, to see if it works for focal epilepsy. Then there is STKO-001. This is an antisense oligonucleotide that increases level of SCN1A in the cell, resulting in an increase in NAV-TI1 protein. And so this is in the preclinical trials for Dravet syndrome. As you can recall, lately, like in the last few years, some of the medications have been specifically approved, FDA approved first for children. Rufinamide is one of them, and clobazam is the other one. Previously, it was always approved for adult first, and we would still use it off-label. I still remember about lacosamide in like 2007, 2008. I would tell the parents it's not approved for children older than 18, but we used it up to 2 years, 3 years, because we only had a couple of handful of medications at that time which were not approved for children. The other one is AM0, and then there is antisense therapy is now being used for the Dravet. It's a mouse model in the preclinical areas. And then Carisbamate is in phase 1 trial for the Lennox-Gastaut syndrome. It is made by the same company who Cinovamate, who makes the Cinovamate, the SK Life. So moving into if the drugs are not helping, we talked a little bit about epilepsy surgery before. So that was specifically for focal epilepsy, epilepsies, and another way. So clinically, for example, if you're seeing a patient and you don't have EEG, you don't have MRIs, nothing. But if they tell you they only have one seizure type, they do not have more than any other seizure type at all, though, even if their MRIs are normal, even if their EEGs have like rare or multifocal spikes or anything, they are still a good candidate for epilepsy seizures, because having just one semiology means the seizure is coming most likely from one focus. And if we can take out that focus safely, can we make this person seizure free? So keep that in mind. So for example, if they have more than one focus, or they have multiple foci on the EEG, what we call, when you read the EEG reports, it will say multifocal spikes were seen. So that means they have multiple foci. So though they will not qualify for the resective surgery, but we can look into what we call the neuro stimulation in them. So the most common one is the vagal nerve stimulator, and then recently they have started to use transcutaneous VNS. The trigeminal nerve stimulation is another modality which is being used, transcranial direct current stimulation, and the transcranial magnetic stimulation. Of these, the most commonly is the vagal nerve stimulation, or VNS as it's commonly called. And these either deliver current directly or indirectly to the brain. It could be invasive or non-invasive, and hence then that's why we use the term modulating the neuronal activity to achieve the seizure suppression. So vagal nerve stimulator is most commonly used, and then deep brain stimulation just got approved, and oh, I forgot RNS. So again, these neuromodulation mechanisms, they're used as an adjunctive treatment. So if somebody comes in with a new onset first time seizure, I'm not going to offer vagal nerve stimulation, because the success rate is 50%. And again, it reduces seizures by 50%. Now, having said that, do have a couple of handful kids where their seizures are completely stopped. They have been off of the medication for several years. But in a lot of them, it's if the seizures, especially, so VNS is especially very good about indication for the convulsive seizure types and the tonic seizures. There has been some case reports about Epson seizures and the complex partial seizures. It will be effective too, but it's very good. So here we're talking about the type of seizure. A few years ago, they were not doing it for genetic epilepsies, but there has been report, and actually we did the trial in Dallas, and we found that even in genetic epilepsies, it is effective. So if somebody with genetic epilepsies is not responding to the medication, already failed 2 or 3, it's not unreasonable to refer them to an epilepsy center for vagal nerve stimulator. And actually, we do vagal nerve stimulators here in the CRS clinic. So it's implanted by the surgeons outside, but once they come here into the clinic, me and Dr. Xambe, we manage them over here. So the vagal stimulation, the side effects are very minimal. So just have hoarseness in the throat or some paresthesias, coughing, dyspnea, very minimal side effects. And so here is, so it's probably a little bit bigger than the coin, like a 50-cent coin. And it's implanted on the on your left side under the clavicle. And you can see there are wires. There are 2 wires which go, and they wrap it around the vagus nerve. So it's a very simple surgery. They put a cut here and put a cut here. Um, and it's less than an hour procedure, and they're sent home the same day. And then so they're given this magnet which looks like a watch. So when they have a convulsive seizure at home or even other seizure types, they just swipe it. So all they do is like they have to touch this generator over here, and it gives an extra flow of current. So the most common setting which we start with is it is on for 30 seconds and it is off for 5 minutes. So it gives, and every time you touch the magnet, it will deliver an extra current. The magnet has a self-locking safety mechanism. So even if you swipe like 10, 20 times in 1 minute, it will not deliver more than 1 minute. So we use this wand in the clinic, and this is the tablet. And then we put this wand on top of the VNS, and then we can download the data. So transcutaneous vagal nerve stimulation has been used. I've never used it. It's less invasive, but it's not being used very commonly. So the deep brain stimulators. So these brain stimulators have been actually being used for movement disorders, especially like Parkinson's, for like 20+ years. So we have a lot of experience. The movement centers have a lot of experience with it. I think it just got approved for epilepsy in 2018, I think. And so you implant the neurostimulator. So over here, just under the clavicle, and then they have the wires. So the wires can go in, and then they put the wires go, and where if you can put one where the ictal zone is, if you can identify 2, and into the anterior thalamus. So the basically wires have to go down into the anterior thalamus. This is where the ADV, and you can actually download the data again from over here. The third one, which is commonly used, is the RNS, as we call it, or responsive neurostimulation. It is made by the company NeuroPace. So and this is interestingly, this is used if you have 2 foci. So for example, somebody with focal epilepsy has 2 foci where the seizures are coming from, then RNS is a good option for them. And so interesting. So the system is able to monitor the electrical changes in the cortical activity, and it gives small impulses or bursts of stimulation to the brain to interrupt a seizure. And the seizure reduction rate is pretty significant. It's close to 70%, which improves the quality of life as well. And we're still again talking about the primarily convulsive seizures. There is some side effect, depressive mood, and the memory impairment. So the interesting thing about NeuroPace is it learns the seizure behavior. So it does not start to work immediately. So sometimes it takes as many as 1.5 to 2 years for it to learn the electrical environment. And then eventually what it does is, as it learns it, as soon as it sees changes in that electrical environment, it gives the electrical impulse to stop the seizure before it starts. And so this is how it looks like. So you place it, it is placed. So this is more invasive than VNS, because you place the device under the skull on the surface of the brain. And then the wand looks very similar to the one we had on the VNS, and you just put the wand here, and you can actually download all the data, all the seizures which may have happened into your computer. So and it's very small. It's like 2.3 by 1 inch neurostimulation. And this is how the X-ray looks like where it is placed. Okay. So then some of the other newer technologies is the laser interstitial thermal therapy. And this is minimally guided MRI, laser surgery technique. And then, so rather than like opening the skull, the surgeons are now using laser fiber. So they just make very tiny small holes, and the heat destroys the laser. So they are, so for hemispherotomies, for example, they used to open the skull, and now they're actually using these newer techniques where they just do the laser like at two, depending on if you're doing anterior or posterior hemispherotomy, then they would do use it just two tiny burr holes, and they do the hemispherotomy for especially, which is good for tonic seizures. So
And Dr. Khan,
yeah.
not to interrupt you, but we will need to finish within the next 5 minutes or so, just
I'm almost
to get
done.
everyone to clinic.
Oh, okay. Okay, I'm almost done. So I just wanted to touch briefly upon some of the wearable devices alerts. So the biggest concern families have is the nocturnal seizures, and especially with kids. They are afraid that they cannot put them to sleep in separate rooms. A lot of the kids are sleeping in the same room as parents. So the only FDA approved device is for the Embrace 2 watch. And again, we need to understand it because it detects the movement. So it only will tell you about the tonic-clonic movements, but not about like the Epson seizures or if you're just staring off. So these are some of the other devices. So this is a new artificial intelligence it's called Nelly. So this was made in 2015 in a lab in Finland, and they actually use it for automatic seizure detection. So this is in phase 3 clinical trials right now. And this is interesting. You just have an audio and a video based monitoring system. So no EEG leads. What the artificial technology is doing, it's trying to identify, because remember, seizure semiology is always similar, even though if you have 4 or 5 seizure types like in Lennox-Gastaut, but they are all going to be very similar. So this learns your seizures and the sounds, and then does it. And what they're doing it with the EEG monitoring. So if, for example, Nelly doesn't pick it up, then the EEG, based on the EEG findings, they're making Nelly learn this. So you have a personal recording unit, you have a computer, camera, and microphone. You don't have to wear anything. And it uses the advanced machine learning. So this is all it is. Like, you sleep in your own bed, and you don't wear anything, and you have an audio video, but it has to be prescribed for at least 14 to 28 days, where it tries to learn the seizure. Some people will often ask about safety pillows. There is no, it's not FDA approved, but some of the people, it is out there. And people have asked me questions about anti-suffocation pillows, where they feel that the lattice network prevents them from suffocation, but there is no data to prove that. People talk about seizure dogs also. Again, there is no study to support it. But that's one of the things a lot of families would be asking, and this is for the drop seizures. And the last thing is, we talk about prevention. So can we prevent epilepsies? Actually, 25% of them are potentially preventable. So these are the post-traumatic epilepsies, so like falls, road accidents, sports injuries, prenatal injuries at birth. Those are an infection. So infection is not common over here, but in third world countries where there are parasites, neurocysticercosis, and tuberculosis, those are potentially preventable. Sorry, I went over time. Okay. Any questions?
All right. Thank you for the presentation. So far, I'm not seeing any questions in the chat box. If anyone wants to unmute and has, I see one
do have
question.
a question.
Yes. Go ahead. I see one question that just popped up asking about ketogenic therapy. Are you able to tell us a little bit about what role ketogenic therapy has in epilepsy and epilepsy syndromes?
Oh, yeah, that's a very good question. I should have added that too. So it is one of the treatments for intractable epilepsy. So the idea of ketogenic diet came around like 100 plus years ago, where people for religious reasons used to fast, and it was noted if they had epilepsy, they would stop. The seizures would stop. So primarily, your brain uses glucose as a source of energy, but then um, when you are in ketosis and and you're fasting, and you then the ketones available, then the brain uses ketones, and for we still don't have the understanding exactly, but it does suppress the seizures. So it is recommended for intractable epilepsies, and but it is like any other medication. It does have side effects, and some of the main side effects is it can cause kidney stones, it causes weight loss, and that's why it is now being used for weight loss, intermittent fasting. And it is hard to make the kids fast. So the diet is changed to high fat, low glucose to normal protein. And if you follow the strict ketogenic diet, it's actually very hard to do it, in the sense it's like a lifestyle change. Even little things like, for example, toothpaste and shampoo, they all have glucose in it. So they have to we teach them how to learn the labels, what to avoid, the sucrose and all of that, and then do it. The other thing is they are in mild, they are acidotic also, so they can go into severe acidosis if you're not careful. And they're also kept so you calculate their caloric count by weight and then also by water. So they're kept in partial dehydration too. So you give them 90% of the what their water requirement is. So this is the very strict extreme. This is what we were doing before. And now in the last 10 years, I mean, since we now have what we call the modified Atkins diet. So some of the newer researchers have studies are showing that even if you don't do such a strict control, you can get a good seizure freedom. It's a lot easy to do if kids are on G-tube, because you have a KetoCal formula, but it is hard to do it if you are eating by mouth. It is done more commonly in pediatric hospitals. I think some of the adult hospitals are not doing it, but it is mostly reserved for intractable epilepsy. And it is only, so you only try it for 2 years. So, and if you do it for 3 months, and if you don't become seizures under control, that means you failed it. So, but if you become seizure free in 3 months, then you continue for 2 years, and then you have to take them off of it, just like you would take people off of anti-epileptic medicines if they're seizure free for 2 years.
Okay. We have another question and follow-up on it. So for some of the specific medications like carbamazepine, what kind of a pre-medication workup do we need to do before starting it? Any labs?
So epilepsy is actually a clinical diagnosis. If it looks like they're having a seizure, what they describe as a seizure, and if they had more than 2 seizures and you want to start them on the medication, you can actually start them even without the EEG or the MRI, because that's not part of your diagnosis. That just helps you finding the etiology. And if for example, the semiology was not clear, like we did not know what the onset was, then you can start them. So if, for example, you're in a third world country, or if you live in a place where the EEG resources are like 2 hours away, or you can start them on anti-epileptic medication based on your clinical findings. And it is good to presume most of the seizures are actually focal. So if you put them on carbamazepine, it's not an unreasonable choice. So, and same as with the adults, most of the seizures are focal. So only with Depakote, I typically do a baseline liver function test. But other than that, with most of the anti-epileptics, I don't do any baseline labs, unless they have other comorbidities, or if they're on other medications.
All right. And then the last question is, if you're switching a patient from one medication, you said you can switch to more of a broad spectrum anti-epileptic. Are you describing then something along the lines of phenytoin?
No, so broad spectrum would be so most common one, the levetiracetam or Keppra. That's broad spectrum. Depakote is broad spectrum. Phenytoin, because of their side effects, I only have like one patient on phenytoin outpatient, and that too because everything else failed on him. So phenytoin, I don't use it as an outpatient unless like diet. That's the only thing left, because of the side effect profile is pretty bad. But it's a great medication to abort the seizure. So Keppra is broad spectrum, lamotrigine is broad spectrum. Glucosamide was initially approved as focal, but now they have said it is good in the generalized epilepsy. So that's a broad spectrum medication. Phenobarbital is also broad spectrum. Benzodiazepines are also all although we don't every once in a while I'll end up using benzos but clobazam is more preferable because it's less sedating than some of the other older benzodiazepines if you want to use it daily. So, and when you do the transition, I usually do it at the same time. You start going up on the new one and you come off of the old one at the same time, because if you come off, some parents insist they want to come off the first one, then you're putting them at risk for breakthrough seizures if you take them off completely first and then start the new one. Does that
Thank
answer?
you so much.
Mhm. I think, are we done? Thank you.